Θα συνεχίσουμε με την καθηγήτρια Β.Βozkurt, που θα μιλήσει για ένα καυτό θέμα στο γλαύκομα. Για πολλά χρόνια μας έχει απασχολήσει και ίσως και ταλαιπωρήσει, την ευρωπροστασία, και θα εξετάσει αν αυτό πραγματικά είναι δυνατό.
Good morning, dear chairman, dear panelists, dear colleagues. I would like to thank Professor Konstas for inviting me in this panel, and I am very surprised for the introduction, and thank you very much for this lovely introduction. Maybe we will negotiate on some points later. Okay. As we all know, glaucoma is a neurodegenerative disease, and intraocular pressure is the risk factor we treat. However, we all know that reduction of IOP to the target therapeutic range is not always successful in halting the damage in glaucoma. So, in our current treatment, we decrease the IOP levels to decrease the progression rate so that we can maintain visual function for the patient until his death. But in fact, in the future therapies, our aim should be to stop the degeneration and even reverse the degeneration. So we can divide future therapies into two. One of them is neuroprotection, which means preventing further neural degeneration, and the other is neuron regeneration. In the PubMed, when we write the keywords neuroprotection in glaucoma, there are about 360 papers. Most of them are in vitro studies on retinal ganglion cell cultures, optic nerve crush injuries, and experimental glaucoma models, animal models. And unfortunately, there are few limited randomized clinical trials. So when we look at the picture, the neurodegeneration, we see that there are many mechanisms going to the apoptosis in glaucoma. With increased IOP, we see axonal transport failure, we see neurotropic factor deprivation, impaired ocular perfusion, exotoxic damage, oxidative stress, inflammation, and autoimmunity. So there are now a lot of molecules. The studies on glaucoma, there are a lot of molecules, drugs that have been extensively studied in glaucoma, and most of them were shown to be neuroprotective in glaucoma, but they are only experimental, and most of them have no human clinical trials yet. So when we look to the neurotrophins, intravitreal supplementation of brain-derived neural factors and ciliary neurotrophic factor, they were shown to enhance the survival of retinal ganglion cells after crush injuries and after experimental glaucoma models. And interestingly, the Lambiase et al., they used neural growth factors as drops, topical drops, on rats with glaucoma. And they were statistically shown that after the use of these drugs, less retinal ganglion cell death is observed in rats treated with these drops. And they used these drops in 3 glaucoma patients, advanced glaucoma patients, for 3 months. And again, they show improvement in visual acuity, visual field, and contrast sensitivity. But the time is so limited, so we cannot conclude a result. But the result seems promising. The exotoxicity with increased glutamate levels and increased NMDA receptor activation seems to be an important pathway in most of the neurodegenerative diseases like Alzheimer's, dementia, and Parkinson. And there are a lot of studies done in glaucoma, and most of the studies, experimental studies, showed that with increased IOP, the ganglion cells and the glial cells, they produce glutamate. And high glutamate they stimulate excessively the receptor, NMDA receptor, open the sodium and calcium channels. The calcium goes into the cell, and with this, the apoptotic pathway is initiated. The neurons degenerate. And the studies showed elevated levels of glutamate levels in the vitreous of both in humans and in animals, in monkeys with glaucoma. So maybe inhibitors of NMDA receptors and calcium channel blockers might help in this aspect in glaucoma. We all know memantine. Memantine is approved for Alzheimer's disease and vascular dementia, and it blocks only excessive NMDA receptor activity. In animal models done by Yeni Yücel, it was shown to be very effective neuroprotective agent in monkey hypertension glaucoma models. But unfortunately, there was a big phase 3 trial with thousands of people, which lasted for 4 years. It showed no beneficial effects in patients with glaucoma. Nitric oxide is a neuronal messenger. And unfortunately, if it's too high, then it reacts with the superoxide anion to form peroxynitrate, which is toxic, which is highly reactive oxygen species. And in glaucoma, it's also shown that the nitric oxide levels increase. So maybe aminoguanidine, which is a potent inhibitor of the enzyme which is used for the production of nitric oxide, may be useful. It's now studied in animals models, but the results remain still inconclusive. We are using antioxidative treatment in many fields of the medicine. And maybe we are using it in our glaucoma patients, in patients with low tension glaucoma, although we do not have evidence-based studies yet. But we have vitamin C, E, melatonin, ginkgo biloba, and its extracts. There are some studies, some experimental studies. Some showed that these inhibit retinal ganglion cell death in nitric oxide or increased IOP models, and some increased blood flow. Now in Turkey, we had a drug, Visiodrop, which combines vitamin C, vitamin E with coenzyme Q10 for ocular surface. But the company says that they are now preparing a drug for neuron degeneration, for glaucoma, and for other neurodegenerative optic neuropathies. Mitochondrial dysfunction is an important issue. Coenzyme Q10 is, very popular in medicine, and it was shown to protect retina after ischemia and reperfusion in the red glaucoma models. And there are many studies done with TNF-alpha. The experimental studies showed that in glaucoma models, the TNF levels increase, and TNF initiates apoptotic pathway in ganglion cells. So maybe inhibiting the TNF receptors, inhibiting the TNF might be helpful, especially in patients who are susceptible, which means that who are genetically prone to produce higher TNF levels after IOP increase. We might think about, for example, infliximab, which we use in uveitis in these patients to stop the neurodegeneration in glaucoma. And the final pathway is apoptosis. In glaucoma neurodegeneration, we see apoptosis. It might be extrinsic stimulations or intrinsic stimulations. The caspase pathway is activated, and until apoptotic, the survival genes decrease, the apoptotic genes increase, and the result is apoptosis, the death of the ganglion cell. So maybe the increased production of survival genes, brimonidine was shown to increase these survival genes, or maybe the inhibitors of caspase, calpeptin or calpain specific inhibitor, might be used in this aspect. Another molecule, the SciEND group is working on it, there are several studies, is erythropoietin. The intravitreal injections of erythropoietin have been shown to inhibit caspase pathway and that signals and rescue retinal ganglion cells both in axotomized rats and in ocular hypertension models. And those toxicity studies in the animals showed that it's safe based on electroretinography, fundus fluorescein angiography, and histopathology. So there are many molecular mechanisms underlying glaucoma, and a number of molecules have been shown to be effective, neuroprotective in experimental glaucoma. However, so far, none of these molecules has found its way in clinical practice because it's too hard. There are too many challenges in translating the basic science, the laboratory science, into real life. So, can in vitro studies model a true model for chronic glaucoma in humans? If yes, which animal? In fact, although we have similarities with monkeys, an animal model cannot properly simulate a human disease. And which glaucoma model? If we are lucky to find a molecule, we have difficulties in formulating the dosages. What will be the delivery regimens? Intravitreal injections will be hard, so we have to use topical ones, and the need for minimal side effects. There are limited human clinical trials because it's so chronic disease and we have to wait long to see the effect of any medications on glaucoma, the neuroprotective effect. And there are variability between patients, not like animals. We are very different. We have comorbidities, we are using different medications, and which test is the best to monitor the neurodegeneration? The visual field, the functional damage, or structural damage? So there are some, to end a conclusion, there are some criteria for neuroprotective agents. Should have a receptor in retina, should reach to the retina, should increase the survival, and its efficacy should be shown in human trials. Among all the anti-glaucoma medication we use, the brimonidine is the one that's mostly studied on its neuroprotective efficacy in the literature. And it was shown to be protective in 3 pathways. It affects 3 pathways. It increases the brain-derived neural factor expression and production. It decreases the glutamate pathway and decreases glutamate levels. It increases the survival genes. So it decreases apoptosis in glaucoma. And there is one study, and all of you know, a randomized trial of brimonidine versus timolol, which is completed in 2011 in low-tension glaucoma study group. The brimonidine and timolol were used in 2 groups. The mean treated IOP was similar for both groups. However, statistically fewer brimonidine-treated patients, only 9%, had visual field progression than timolol-treated patients, which was 40%. However, as we see, brimonidine-treated patients discontinued because of the adverse effects. It's 28.3. So is neuroprotection so far away? There are lots of studies, but although there are barriers, we still hope that we will find some medications to neuroprotect the cells. Thank you very much.
Και θα τελειώσουμε με την παρουσίαση του καθηγητή Μουράτιρ Κέτς. Του ζητήθηκε